Now, we all know about the circle of life, and we all know that as we are born, so must we die. And our scriptures tell us that to everything there is a season and a time. But what happens when out of season and out of time, death suddenly forces itself into the heart of a family? What happens when a productive, self-reliant individual suddenly realizes that she has no time? She's not going to be able to realize her dreams and her goals and her ambitions. And finally, what can we, as their physicians and caregivers, do to help in improving the quality of life and providing support to these patients and their families? It's our bounden duty to walk with them the last few steps of the way. The problem is, we often don't know how. Madhuben was an active 68-year-old, deeply religious woman. She was suddenly diagnosed with non-Hodgkin's lymphoma in April of 2000. Her son and daughter-in-law, both doctors, thought it best to be completely honest with her about diagnosis and prognosis and treatment, and they told her lymph nodes are going to melt like wax. But they didn't. They kept coming back. By August of 2000, all the different combinations of chemotherapy, both strong and diluted, had been tried out. By this time, the honesty was also diluted. She was repeatedly reassured that everything was fine. This is just a temporary setback. Everything is going to be fine. She left this world a few weeks later, ravaged by this disease, surrounded by a loving family, but not having had that outlet for her emotions, for her anxieties, and for her fears. Madhuben was my mother-in-law, and to this day, I constantly regret not having been more honest with her in the end. In trying to protect each other, patients and relatives don't discuss these things, and finally, the patient doesn't have this very, very valuable and necessary outlet at the end of her life to express her anxieties about dying, her fears, and her wishes. It was only her deep religious commitment which got her through this difficult time, and this is very common with our Indian women. Now, this is a very, very well-known picture, but I want you to look more closely at the compassion in the doctor's face and the comforting hand on the patient's shoulder, and look at the expression in the mother's eyes. Patients and relatives don't look to us just for treatment. They look to us for much more, for information, for reassurance, for guidance, for hope, for care, for support. So in our drive to control the disease, we sometimes forget that the disease dwells in a human being with a mind and a spirit that needs attention too. Good palliative care is concerned with enrichment of life even while dying, and we as physicians must play a very important part in enriching the lives of our dying patients. This is a photograph of our hospice center. It's lovingly created with verdant green surroundings, but in our context, hospice care is not as important. It is the support given by family members, friends, and caring physicians, which gets the patient through these last few stages. So it's a very, very important aspect of medicine. And we have no guidance. Which courses do we have in medical syllabuses? I was never trained how to talk with a dying patient. Most of the time, we rely on our instinct and our innate sensitivity. Most of the time, it works out all right, but sometimes it doesn't. This is a painting by an artist who was struck with leukemia, and he said, he said he felt as if he's between night and day. And he said, suddenly illness arrives, uninvited and unexplained. I found myself banished to an unknown place between night and day. The illness forced itself into my life where there was no place for it. It stole a place and time that should have been destined for better things. And this is what happens to a patient when he's suddenly struck with this horrible news of terminal illness. So the patient, the human mind is a fantastic thing. And the patient, and to the extent, some extent, the relatives also, they undergo certain coping mechanisms by which they can sort of accept this horrible news. And we need to know and understand when the patient is undergoing these coping mechanisms. The first of these is usually denial, and we see it all the time. No, not me, it can't be true. The slides must have been mixed up. These probably aren't my x-rays. I want to see another doctor. I want to change my hospital. We shouldn't worry when the patient is in denial. It's a protective role, and it's a healthy way of dealing with the painful situation. It actually acts as a buffer, allowing her to collect herself and giving her an opportunity to mobilize her defenses. Hopefully, it's usually a temporary defense and is soon replaced by partial acceptance. So when a patient or her relative refuses or denies the situation, one shouldn't get angry with them. The next phase is anger. When she can no longer deny it, she's angry. Obviously, she's angry. Why me? I'm a productive, self-reliant individual. I have a young family to look after. Why not that poor, sick, old beggar sitting on the road? He has no family. He has no money. He has no friends. He has nothing to do. Why me? I have so much left to accomplish. This is very difficult for us to deal with because very often this anger on the patient's or relative's part is misdirected at us. And we should understand where it's coming from. They're not really angry with us. The next phase, and we see this very often, is bargaining. I have to attend my son's wedding. My daughter's going to have a baby next month, and I have to be there to look after the child. This is a very, very human emotion. It is trying to postpone the inevitable. We have to gently explain that this is not in our hands. Whatever time she has left, we are going to be there to improve her quality of life. Obviously, depression. Who would not be depressed? This doesn't mean it's a medical depression requiring antidepressants, but everybody would be depressed and would go into a phase of despair. Who is going to look after my children? Who's going to accompany my spouse? Very often they feel they're repugnant to their partner after a mastectomy or a colostomy, for example. The financial burdens can be huge, especially with a disease like cancer. In this phase, they require a lot of reassurance, and we need to make the spouse and the relatives look after the patient at this time, to assure them that insurance is there, to assure them that they're still physically very attractive. About the children, they can be reassured that their children are just as happy playing in the neighbor's garden. They're still attending school, getting good grades, attending birthday parties. This may sound small, but this all adds up to an enormous amount of relief and comfort level for the dying patient. Finally, if she's been allowed to go through these phases and she's helped through these phases, she finally reaches a phase of acceptance. And acceptance doesn't mean she's happy about it. It's quiet, withdrawn phase. And in our situation, the religious and spiritual beliefs of the patient help them enormously in this phase. And actually, the patient now starts helping her relatives to cope if she is allowed to do it. And in this phase, we very often find relatives coming more to us and requiring reassurance than the patient. And this is a verse from the Gitanjali, which I thought really epitomized the phase of acceptance. I have got my leave. Bid me farewell, my brothers. I bow to you all and take my departure. I give back the keys of my door, and I give up all claims to my house. I only ask for last kind words from you. A summons has come, and I am ready for my journey. So these are the coping mechanisms which finally lead to a phase of acceptance, and we see them also in relatives, not only in patients, and we see them every single day. This is a postcard painted by one of our patients, a little child with leukemia, and I always feel it symbolizes hope, and man can't live without hope. So now that we know what the patient goes through, we have to deal with it, and we have to start talking to the patient. And the first question, which always arises in our Indian context, is, should she be told? And usually the relative comes in first and they say, tell us whatever it is. Don't tell her, it'll kill her. Of course, this is not true. The patient half knows the truth anyway, and she's in a great state of confusion. And most of the time, not directly, maybe not at that session itself, gradually perhaps the patient has to be told and wants to be told the truth. I think that